Hi everybody, this is Dr. Chitra here and a mentor at StudyEFOG, and we are back with our RRR series to help you in your preparation for your EPCOG Part 1 exams. And today I am here to discuss a few questions on maternal medicine. So let us begin. Remember one thing, that hard work beats talent when talent doesn't work hard. So even though you have the talent and you do not work hard, you are not going to succeed in your exam. So remember that, put in a lot of hard work and you will succeed in your exam. Now the learning objectives are to know important points in the following topics and how to solve SBAs and EMQs in hypertension in pregnancy, diabetes in pregnancy, and infections in pregnancy. So let's begin. Hypertensive disorders in pregnancy, we know it could be chronic hypertension superimposed with preeclampsia, or gestational hypertension. Now let us see about preeclampsia. So which are the biomarkers that are advised to be done in women suspected to have preeclampsia? The answer is SFLT1 or a PGF ratio. Okay, so this is done at around 20 to 35 weeks of pregnancy, and if you do this ratio, it helps to rule out preeclampsia in a woman requiring delivery in 1 to 2 weeks. So if you have a low PGF or a high SFLT rate, or if the ratio of SFLT to PGF is high, then it indicates that this woman is at a very high risk of developing preeclampsia. Now, which are the tests that are advised to monitor the severity of preeclampsia? Blood tests. So remember, it is hemoglobin, because we know that in women with preeclampsia there could be hemoconcentration. Platelets have to be done to rule out a low platelet count or thrombocytopenia. Liver enzymes like AST, then uric acid, creatinine, serum albumin, all this to know liver function and renal function tests. And to know the coagulation profile, you should be doing the INR, fibrinogen, D-dimer, and antithrombin and haptoglobin. The fetus is also not to be forgotten. So how do you monitor the fetus? The woman should be asked to report any lack of fetal movements, plus you can do a CTG to know how the fetus is coping up inside in the utero. You can do an ultrasound biometry and a biophysical profile, and don't forget to do a Doppler of umbilical artery, middle cerebral artery, and ductus venosus. Now let us see at a few SBAs. So pause the video here, okay, and then read the question very carefully and then look at the correct option. So you have this primey, 41 years old, 34 weeks of gestation. She has high blood pressure. She has headache. On admission, her pressure is 160 by 110. It settles down to 140 by 90 after you have given her oral labetalol. And her examination is as follows. It's a singleton pregnancy. Symphysiofundal height is 30 centimeters. Uterus is relaxed. CTG is reactive. She is conscious and oriented. No hyperreflexia, but bilateral lymphedema is present. Hemoglobin is 100, platelets are 135, urate 384, transferase is 23, urine protein creatinine ratio is 0.5. That means there is significant proteinuria. Now choose the most appropriate management option for her. So remember one thing, that her pressure has settled down and she is still only 34 weeks. So you can offer her a conservative management. Now everything has been done for her except they have not really looked after the fetus very well. So the obvious choice would be arrange an ultrasound for fetal biometry, like her volume and umbilical artery Doppler, and keep her under observation. Give her conservative management. Okay. Now you have another 30-year-old multi, 20 weeks of pregnancy. Pressure is 155 over 105 millimeters of mercury. At booking at 10 weeks, her pressure was 150 by 100. Urine analysis did show 1 plus proteinuria, and a spot urinary protein creatinine ratio is 35. 24-hour urine collection shows 0.5 grams of proteins. So which of the following is the most likely diagnosis? Remember, she is hypertensive even at the booking visits. That means early pregnancy also she is hypertensive. And now in the mid trimester, instead of having a fall in pressure, she is showing a rise in her pressure. So most likely it is chronic hypertension with superimposed preeclampsia. Okay, because hypertension in the first trimester, and we know that preeclampsia means any hypertension that is developing after 20 weeks of pregnancy and it is accompanied by proteinuria, you will call it as preeclampsia. So this woman already has chronic hypertension. On top of that, superimposed to that, she has preeclampsia. Now you have this 35-year-old primey, 33 weeks of pregnancy. She is giving a history of headache, blurring of vision. For one day, her blood pressure is 180 by 110. Urine analysis is showing 3+ proteins. 1 week prior, her pressure was 120 by 70. There was no proteinuria. So which is the most appropriate initial drug to administer to her? She is having hypertension. Not too much of hypertension, but she is symptomatic. Okay, so you do not want her to throw a fit. So the first drug that you would offer her is magnesium sulfate to control her symptoms, and then you can give her an antihypertensive. So if you give her an antihypertensive, it is not going to control her seizures. So first give her something to prevent the seizures, and then you can give antihypertensive. Now you have this 45-year-old induced at 36 weeks of pregnancy for preeclampsia. Okay, the midwife wants you to come and see her urgently as the patient is complaining of severe headache, epigastric pain. Her pressure is 140 by 90, reflexes are brisk, and she has clonus. So what is the most appropriate management step for this woman? She is symptomatic now, remember. So the first thing that you would want to do is you will try to control her symptoms. So among the options given here, magnesium sulfate is the best option because that is the one that is going to prevent her from throwing an epileptic seizure. Now the definitive treatment for this woman would be to expedite her labor, but that would depend on what is the clinical finding at that time. If she's fully dilated, you can do a forceps delivery or whatever. But right now it is important to control her symptoms. So you first give her magnesium sulfate and then think about the mode of delivery. So first stabilization and then you try to deliver her. Now you have this another lady, Lucy. She is a type 1 diabetic. She's also hypertensive. She is taking insulin and captopril to control her medical conditions. And she has taken folic acid 5 milligrams. And she has come to you for preconceptional counseling. So what advice would you give to her? Read the question very carefully. She wants to attempt a pregnancy, but she's taking captopril, a drug which is not really safe during pregnancy. So just see if in the options you have something related to captopril. So option D, that is need to change captopril, that is the best option that fits here. She can change to a medication that is more safe in pregnancy. Otherwise, what you have to tell her is that she has to immediately report once the pregnancy test is positive, and within 48 hours you have to change the medication from captopril to something that is safe in pregnancy like labetalol, nifedipine or methyl-dopa, depending on any allergies or anything that she has. Now you have another lady, Annie, 32 weeks pregnant, 42 years old with chronic hypertension. She is taking aspirin, labetalol 200 milligrams twice a day. Pressure is controlled on 130 by 80, but she wants to know when you are going to deliver her. Now remember, this is chronic hypertension and she is well controlled on her antihypertensive. So there is no hurry to deliver her very early. So you will offer her delivery at or after 37 weeks. Okay, women with chronic hypertension, do not offer them early delivery if they are well controlled on medications. Now you have this primey. She is induced at 37 weeks of gestation for preeclampsia. She is taking 200 milligrams of labetalol 3 times a day. She is 4 centimeters dilated at present. The midwife is calling you because she is having a seizure. So what is the first most appropriate step in her management? Now, when you see someone who's having a seizure, the first thing that comes to your mind is, oh my God, I have to give her some drug so that the seizure will stop. But relax. Do not panic. The eclamptic seizures, they last maybe from 30 to 40 seconds. After that, the seizure will stop. So anytime you have any obstetric emergency, remember the first thing that you have to do is you have to look at the airway, breathing and circulation, then call for help and then start giving medications. So here what fits into this is option A, that is assess airway and turn to left lateral with oxygen supplementation. So always remember A, B, C, then call for help and then do the further management. Now, the International Society for Prevention of Hypertension in Pregnancy recommends women with high risk for developing preeclampsia are treated with low-dose aspirin in the next pregnancy. So remember, they are asking which of the factors is not a high risk to be treated with low-dose aspirin. Prior preeclampsia, chronic hypertension, pre-gestational diabetes, family history of hypertension or APLA syndrome. So you have to know which are the high-risk factors. Among this, family history of hypertension is not a high risk factor. The others are high risk factors. Okay, now stop the video and read this. So you have this lady, 3 hours, she has delivered 3 hours ago. She has undergone cesarean section for preeclampsia and she is being treated on IV labetalol and magnesium sulfate, which have been commenced prior to delivery. But the nurse now is concerned because she is becoming lethargic. And her observations are given as follows, which shows that the pressure is normal, respiratory rate is less, 10 per minute, pulse rate is 85, oxygen saturation is alright, 93%, but urine output is 10 ml. So what is the most appropriate immediate action for her? When you look at the scenario, think what does the woman have? The woman is going into magnesium toxicity. So what is the first thing that you will do whenever there is magnesium toxicity? Stop the magnesium sulfate infusion. Do we have an option like this here? Yes, we have the option E, that is stop magnesium sulfate infusion and then check magnesium levels. So you can check magnesium levels, that will come later on. First thing is stop magnesium sulfate infusion and then later on, if necessary, you can give calcium gluconate or whatever other treatment you can give later on. So this is an algorithm on how you are going to monitor magnesium toxicity. Remember a few important things. Anybody who is on a magnesium drip, the patient has to be monitored very carefully. So the pulse rate, blood pressure, respiratory rate, urine output and deep jerks, they have to be monitored very carefully. Respiratory rate, if it becomes less than 16, if the deep jerks are absent or urinary output is less than 30 ml per hour, it indicates that this woman is going into magnesium toxicity. And the first thing that you have to do is you will stop the magnesium sulfate infusion. If still you feel that the respiratory rate is not good, then you can give the antidote to magnesium sulfate, which is 10 ml of 10% calcium gluconate, which is given over 10 minutes. Okay, now a few EMQs. So I want you to pause the video here, read the options on the left which are given very carefully, and then read the questions, the scenarios, and then read the correct answers. So you have this 39-year-old woman in the postnatal ward awaiting discharge. She delivered 2 days ago. She wants to breastfeed her baby. She has chronic hypertension. She was taking enalapril prior to pregnancy, but her medicine during pregnancy was changed to methyl-dopa and she was controlled on this. Now we know methyl-dopa has to be stopped within 48 hours of delivery, so you cannot continue methyl-dopa for her. You want to give her some other medicine which is safe in breastfeeding. Now the options, among the options here, labetalol can be given during breastfeeding as well as enalapril. I would choose enalapril because this is a drug that the woman is already taking prior to pregnancy, so it is better to restart her on the same drug. Now in the next scenario, you have this woman who is at a high risk of developing preeclampsia. So for her, you will start low dose aspirin from 12 weeks of pregnancy until childbirth. Okay. And the last question is, you will start labetalol because that is the first choice of antihypertensive for women with preeclampsia or gestational hypertension. Now another set of EMQs. So this is about, it's a progressive scenario kind of thing. A woman is sent to labor ward by midwife with raised blood pressure. On admission, her BP is 160 by 100. She has no complaints. So though there is high blood pressure, there is no signs of severe preeclampsia, no headache, vomiting or something like that. So you can treat her with oral labetalol. So the first option would be to give her oral labetalol. Okay, so that you have the option of E, treat initially with oral labetalol 200 milligrams. Now this woman, her pressure does not settle down over the next hour and she starts to complain of her headache. And now her pressure is 180 by 115 millimeters of mercury. Now she has not been controlled with oral labetalol. The next thing that you would like to do is you would like to start an IV infusion. So start option A, start IV labetalol infusion. This woman, she underwent a cesarean section and after that she had a brisk bleed on return to the recovery room. That means she had PPH, adonic PPH. Now remember, this woman is hypertensive, so you would not want to give her symptometrin, or you do not even want to give her carboprost. The best drug that you can offer for her is a syntocinon bolus or an IV infusion. So let us see if we have that. Here we have option A, which says treat with syntocinon. Please do not choose option F, which says ergometrin. Remember, ergometrin is contraindicated in women, those who have hypertension. Now after the cesarean section, after 2 hours, her urine output is 30 ml and there is no evidence of PPH. What I would have preferred is there should have been an option of giving a fluid challenge first with crystalloids. So there is an option here, but it says that repeat fluid challenge with a liter of crystalloids. We have not given her any fluid challenge. This is the first time that we are giving her a fluid challenge. So option B, that is give a fluid challenge of 500 colloids over 30 minutes. That is the one that I chose. Then 2 hours after the fluid challenge, the woman has passed 50 ml of urine, which is quite acceptable. So what are you going to do for her now? Remember, she is hypertensive. You do not want to overload her with fluids because then it would precipitate pulmonary edema or cardiac failure. So what the guidelines say that in women when there is no active bleeding now, restrict fluids to 85 ml per hour, but keep a watch on the urine output. Okay. So option C, which says that continue hourly urine volumes and restrict fluid intake to 85 ml per hour, that would be my choice for her. Okay. So these are the answers here for you. Okay, so you have this pregnant woman with a BMI of 35. She underwent a 2-hour 75 gram oral glucose tolerance test at 24 weeks of gestation. So according to the NICE guidelines, which of the results would confirm a diagnosis of GDM? Whenever you are answering SBAs, always don't go to the options immediately. Read the question, think what would be the correct answer, and then have a look at the options. Okay, so NICE guidelines is 5, 6, 7, 8. Now among the given options, which of them fits? Fasting glucose of 5.5? No. 1 hour is not done, so B option is out of choice. 1 hour again 7.8? No. It is 2 hours 7.8. Then 2 hour of 7.6? No. 2 hour glucose of 7.9? Yes, that fits into the diagnosis because it is 5, 6, 7, 8. So 2 hours of more than or equal to 7.8. Here it is 7.9. So this is the correct option here. Okay, 1 hour is not done and fasting should be 5.6 or above. So how do you diagnose GDM? Remember, there are a lot of guidelines. So NICE says it is 5, 6, 7, 8. You also have to remember the International Association of Diabetes and Pregnancy study, which says the cutoff is for fasting more than or equal to 5.1 and 2 hours after glucose 8.5. So remember both of these, because in European countries both the cutoffs are being used. So NICE and International Association of Diabetes and Pregnancy. These are the two values at least which you should be aware of. Now you also have to remember the risk factors for GDM. So a BMI of more than 30, a previous baby weight of more than 4.5 kilos, previous GDM in the previous pregnancy, then family history of diabetes, minority ethnic origin. So all these women, some of the countries offer universal screening, some of the countries say screening only to women, those who have any high risk factors. Now among these, which is the one that is the most high risk and for which like the woman has a history of this particular condition, so you would advise GTT at booking. It is history of GDM, because these women are prone very high risk of developing a GDM in the next pregnancies. Okay. A few more questions on diabetes. So you have this primey who is a type 1 diabetic. She is admitted in labor at 37 plus 2 weeks of gestation, and she is on a sliding scale of insulin infusion. So the midwife wants to know between what levels you want to keep her glucose levels during labor. The correct option here is between 4 and 7, because that is what is advocated in the guidelines. You do not want the woman to become hypoglycemic, at the same time you do not want her to be hyperglycemic either. So 4 and 7 is the ideal level in which she should have her sugar levels in labor. Okay. Now you have this 31-year-old woman, well-controlled type 1 diabetes. She is admitted for induction of labor at 37 weeks. She has a spontaneous previous vaginal delivery. She is 6 centimeters dilated, but the midwife notices that now her sugar level has dropped to 3.5 millimoles per liter. She has no signs and symptoms of hypoglycemia. What would you do for her? So remember, whenever there is hypoglycemia, yes, you would want to give her something with some glucose. But what will you give her with glucose? If you give her uncontrolled glucose, what is going to happen? She will end up in hyperglycemia. So you will commence IV dextrose, and at the same time you will also give her an insulin infusion, because remember, we want her sugar levels to be between 4 and 7. Okay. Okay. You have a mother who has delivered her 4th baby normally. She is type 2 diabetes. She was taking metformin, okay, prior to her pregnancy, and she continued it during pregnancy. From 32 weeks of gestation, she was put on insulin in addition to her metformin. Now this woman, she has delivered and she wants to breastfeed her baby. So in the postpartum period, what advice would you give her regarding her diabetic medications? Okay, so remember that any woman who is diabetic, once they have delivered, the need for insulin or any of the oral hypoglycemic agents that they are on, it falls dramatically. Okay, and in addition to that, they are breastfeeding the baby, so they are very prone to develop hypoglycemia. So what are the guidelines? The guidelines say that any new drug that you have started in pregnancy, you should be stopping the drug, and she should go back to her pre-pregnancy drugs. So for this woman, what you can tell her is she will stop insulin, because that has been started for her during pregnancy, and she will continue metformin as her whatever dosage she was taking in the pre-pregnancy period, and in addition to that, you will keep on monitoring her blood sugar levels. Okay. Now about management of GDM. So you have this primey, 40 years, BMI of 40, and her fasting is 6.8. 2 hours after glucose is 7.9, and the baby is at the 90th centile. So what are the management options for her? Now remember, she is GDM. In addition to that, she is also having a complication. She is having a macrosomic baby. So remember that whenever there is macrosomia and the fasting is more than 6, or whenever it is between 6.1 to 6.9, you will start insulin for her immediately. Lifestyle changes have to be offered to all women, and in addition to that, you might or might not start metformin. Okay, so the correct option for her is lifestyle changes, insulin injections plus or minus metformin. Okay, stop the slide here and go through all the options. So whenever fasting is less than 7, what we do is you offer lifestyle changes, like dietary changes, exercises, and then you call her back after 2 weeks again to check how much is her fasting. If the targets have been met, she can continue with lifestyle changes, but if the targets are not met, you can either start metformin or insulin. Whenever the fasting is more than or equal to 7, the guideline says that immediately start insulin plus or minus metformin and change in diet and exercise. And whenever fasting glucose is between 6 to 6.9 and there are complications, then that is an indication to start insulin plus or minus metformin. And remember, lifestyle changes have to be offered to all women with GDM. Now there are two questions here. Basically, in the first scenario, you have this woman, type 1 diabetes, 36 weeks of gestation, HbA1c of 6.5, so she is fairly well controlled. Post lunch urine is glucose 2 plus, so that is acceptable. Okay. Scan done shows the baby is also within the normal range, it is at the 40th centile. So what will be the plan of management for her? Do you want to admit her to control her glucose levels? No, because it is under control. Induction at 37 to 39 weeks, yes, that looks to be the good option because she is type 1 diabetes and well controlled. So for these women, you will offer to deliver either by induction or by CS, depending on what is the clinical picture at that time. There is no need to increase her pre-lunch insulin nor offer her CS. Women those who are having GDM, VBAC is not a contraindication, or nor is induction of labor a contraindication. So the correct option here is induction of labor at 37 to 39 weeks. Now in the next scenario, lady type 2 diabetes, HbA1c of 7.4 at 34 weeks. The first thing that should ring in your mind is this: her diabetes is not well controlled. The scan shows baby at the 70th centile. It is in the normal range. But what will be the management plan for her? She is only 34 weeks and diabetes is not controlled. The best option for her is you will admit her and control her blood glucose levels, because you want to know what is the exact reason, whether her insulin requirements have increased or she is not compliant with her medications. So under supervision, you want to give her the drug and make sure that her diabetes is under control. Okay. Now, what about retinal assessment? So, primary with diabetic retinopathy, at what gestational age will you offer screening for retinal assessment? The answer is between 16 to 20 weeks, because that is what is given in the guidelines. Okay. You have a 35-year-old P2, previous LSCS, delivered 3 years ago. She has GDM in this pregnancy and she has come to you to discuss her mode of birth. Her GDM is well controlled and she wants a VBAC. Sorry. What will you tell her? Remember what I said in the previous slide, that VBAC is not a contraindication. But she is GDM and she is well controlled. So for women, those who have GDM, they can deliver by 40 plus 6. Do not allow them to become post-date. That means pregnancy should not be extended above 41. So here the correct option is option B, that GDM is not a contraindication to VBAC and she can deliver by 40 plus 6. Okay, like I told you previously, those who have DM and well controlled, deliver them between 37 to 39. If any complications, deliver them early. Women those who have GDM, that is well controlled, they can deliver by 40 plus 6. And diabetes is not a contraindication for VBAC. Now a woman, she has GDM, delivered at 40 weeks. At 6 weeks, she came back and to the midwifery unit, and she wants to know whether she has diabetes mellitus or not. So what the question is asking basically is, the midwife wants to know what kind of test you can do for her, okay, and what would be the normal test, what would be the normal result of the test. So remember, um, women those who have GDM and whose sugars returned back to normal in the immediate postpartum period, for these women you can offer a fasting blood glucose level at 6 weeks of pregnancy, after 6 weeks in the postnatal period, and if that level is less than 6, then you can assure her that she does not have diabetes at present. Okay. I want you to read all these levels, and they are really important to remember. Sorry, because in diabetes you really have to remember a lot of figures. So you can either do fasting blood glucose at 6 weeks postpartum, or if it is not convenient for the woman, if she comes back later at 13 weeks, you can also do one HbA1c. Now you are in the preconceptional clinic. You have a group of women. So among these women, for whom would you strongly advise against a pregnancy? Okay. So 38-year-old with type 2 diabetes and non-proliferative diabetic retinopathy. 22-year-old with BMI of 35, first degree relative with type 2 diabetes. 35-year-old with type 1 diabetes, creatinine of 97. 37-year-old, history of GDM controlled with insulin in her last pregnancy. That means she is not diabetic right now. And 26-year-old, type 1 diabetes, HbA1c of 88 millimole per liter. So this is the one for whom you will advise against a pregnancy. Okay. So anyone who has an HbA1c of more than 10% or more than 88 millimoles per liter, advise them that there is a very high risk of pregnancy complications both for the mother and for the baby, and they have to optimize their health before they embark on a pregnancy. Now a few AMQs. So what would be the management options for these type of women here? Okay, in the options you are given a list of drugs, and then you are given the scenarios. So the first scenario is 34-year-old woman. She is newly diagnosed with GDM at 24 weeks of pregnancy. She has been put on lifestyle changes, but she is not well controlled. So which medication is the most appropriate for her now? The first choice that we saw is metformin, because that can be given in pregnancy. And remember, in addition to metformin, she also has to continue with her lifestyle changes. It is not that she will not continue with lifestyle changes. Okay. Now the second scenario, you have a woman, type 2 diabetes. She is taking sitagliptin prior to pregnancy because she could not tolerate the gastrointestinal side effects of metformin. She was changed to insulin in the antenatal period. She has delivered and now she wants to breastfeed. So if she wants an oral hypoglycemic agent, what would be recommended for her? Remember, she is not able to tolerate metformin. So which is the next drug that is advisable in the postpartum period, especially for women those who are breastfeeding? It is glibenclamide. The others, oral hypoglycemic agents, we usually do not give in women those who are breastfeeding. Okay. The third is a woman with a BMI of 32. She has persistent glycosuria. GTT shows that fasting is 7.1 and 2R is 10.2. Obviously, yes, this is frank GDM. So what will you give her now? Okay, remember, fasting more than 7 is an indication to start insulin. Now, in pregnancy, we usually do not start long-acting insulins. You either want to give short-acting or you want to give intermediate-acting. And the most commonly used insulin in pregnancy is isophane or NPH. Okay, because long-acting insulins are usually avoided in pregnancy unless the woman is a type 1 diabetic and she has been taking the long-acting insulins prior to pregnancy. But in pregnancy, we usually do not start long-acting. So the commonly used insulin in pregnancy is NPH, and that is the one that you would be starting for this woman here. Okay. Next is, let us see a little bit about infections. So the common infections that you should be aware of is chickenpox, herpes, CMV, rubella and parvovirus. Okay. Commonly asked question is that uh, a woman 16 weeks of pregnancy, she presents to the GP with a history of rash, fever for 2 days. She has a son at home who is diagnosed to be suffering from chickenpox, and she is the only one who is looking after the child, so she cannot isolate herself, and obviously she has a very good infection, like the chance of infection is very high. She doesn't know, or she has no history of having chickenpox herself as a child, so now she is worried about what will be the effect of this infection on the unborn child, assuming it is chickenpox. So what will you counsel her? Remember, this woman, there is no history of chickenpox. Okay, so no risk of infection, or a small risk of 1%, less than 1% fetal varicella syndrome, high risk of fetal varicella syndrome, likely to have a spontaneous miscarriage, will lead to intrauterine death. Remember, even if there is infection, usually it does not lead to miscarriage or intrauterine death. The correct option is that there is a small risk of less than 1% of fetal varicella syndrome. So you have to follow this algorithm here. Remember, the guidelines have changed, and the most important thing that you have to remember is that previously um, immunoglobulin was the one that was given. I mean, it was not it was acyclovir. Yeah, immunoglobulin was the one that was given to prevent the development of chickenpox. But the new guidelines say that you can give acyclovir. If acyclovir is contraindicated or not available, then you can give immunoglobulin, okay, as a prophylactic measure. So that is the most important thing that you have to remember here, okay. Now you have this 26-year-old woman with pelvic girdle pain. She has been booked for induction of labor at 39 weeks. She has been diagnosed with primary varicella zoster virus infection at 38 plus 6 weeks of gestation. So what would you recommend to her to reduce the risk of neonatal varicella infection? Remember, it is varicella, okay. Delay induction for 1 week, deliver by elective cesarean section, give intravenous acyclovir for the neonate, intravenous acyclovir to the woman in labor, or oral acyclovir for the mother whenever you have diagnosed her infection. So she is not in labor, but she has been booked for induction of labor. So remember that whenever you are going to have a planned delivery for any woman who has varicella infection, uh, it takes some time for the woman to form antibodies, and these antibodies will then be transferred across to the mother. So normally they say that any woman who has active varicella infection, do not deliver her immediately if possible, and here she is for induction of labor, so that you, if the fetus is doing good, you can always delay it for 7 more days. So in that 7 days the mother will form antibodies. Those antibodies will cross across the placenta and they will protect the baby. So then there is very little risk of neonatal infection. Okay. Now coming to herpes infection. So you have this primary genital herpes infection at 30 weeks of pregnancy. The first episode was treated with acyclovir, and she was advised suppressive therapy until birth. Now this lady, she refused a cesarean section and she opted for a vaginal birth. After birth, baby was well. But what is the advice regarding acyclovir that you will give for the newborn? Remember, she has primary herpes infection in the 3rd trimester. She has delivered vaginally. She has refused a cesarean section. So this neonate is at a very high risk of developing neonatal herpes. So for this child, you have to say that you will prescribe acyclovir 20 milligram 3 times a day while awaiting the swab results. Swabs will also be taken for the baby even though the baby appears normal at birth. Just because this lady has primary herpes infection in the 3rd trimester and she has not delivered by a cesarean section. Okay, if you deliver her vaginally, the baby has a very high risk of getting neonatal herpes infection. Okay, so this is the algorithm that you have to follow. Pause the video for 1 minute, read the algorithm very carefully. Now you have this 25-year-old para 1, 39 weeks of gestation, previous delivery by cesarean section, and she has come to discuss her mode of birth. So the midwife has referred her to you because the lady has active primary genital herpes infection. This lady is very keen for a vaginal birth. What will you advise her regarding the mode of birth in this pregnancy? Remember, it is a case of active primary herpetic infection. Okay, very high risk for the baby if she has a vaginal birth. Okay, so will you tell her vaginal birth is safe? No, it is not safe for the baby. Cesarean section is advised? Yes, because in that way you will prevent infection to the fetus. Induction of labor with Foley is of course not indicated because you do not want to give her a vaginal birth. Oral acyclovir and induction of labor when lesions are crusted over, not advised. And intravenous acyclovir and induction of labor by amniotomy, these are also not indicated. So you will tell her because it is active genital herpes at term, she will deliver by a cesarean section. Okay, because if she doesn't, then the risk of the baby getting herpetic infections is up to 41%. Now you have this 26-year-old primey, 36 weeks of pregnancy, diagnosed with CMV. She is concerned about her mode of delivery. What will you advise her? No contraindication to vaginal delivery. Remember, it is CMV. Okay. Elective section at 39 weeks, elective CS at onset of labor, very high risk of infection to the baby, either by vaginal birth or by CS, or start acyclovir immediately. Remember, CMV is not an indication to do a CS, nor is it a contraindication for vaginal birth. Okay, so you will tell her that there is no contraindication to her vaginal delivery because she is concerned about her mode of delivery. So the other options are not really applicable, and CMV, whether primary infection or secondary infection, first trimester, second trimester, third trimester, whenever it is there, it is not an indication to do a CS. CS is indicated only for obstetric reasons. Okay. Okay. The GP has called you for advice of this 25-year-old woman, 14 weeks pregnant. She has presented with a history of rash for 1 day. There are red spots behind her ears, across her head, neck, trunk and legs. She has painful swelling behind her ears. Her temperature is 38 degrees Celsius. So the GP is thinking that probably she has rubella infection. Remember, she is 14 weeks pregnant. So what is the most appropriate statement about the risk of fetus in the case of primary rubella infection in this case? Okay. Risk to the fetus of primary infection after 20 weeks is substantial. The risk to the fetus between 16 to 20 weeks is substantial. The risk to the fetus of primary infection in the first 16 weeks carries a minimal risk of deafness. Risk to the fetus of primary infection in the first 16 weeks carries no documented risk. Or risk to the fetus of primary infection in the first 16 weeks is substantial. Remember that risk to the fetus of primary infection in the first 16 weeks, it is substantial. After that, if there is infection, then it is there will not be any congenital anomalies in the baby. There is only a little risk of sensory neural hearing loss. Okay, only deafness is there between 16 to 20 weeks. Now coming to GBS. So you have this primey who has come with contractions, 3 contractions in 10 minutes and 36 weeks of gestation. An examination reveals that there is the membranes have not been ruptured. She is 6 centimeters dilated. Now this woman, she has been treated at 29 weeks of gestation for GBS bacteriuria. But a vaginal swab that was done at 32 weeks of gestation did not grow GBS. But she had bacteriuria. Okay, and that bacteriuria has been treated. So what is the most appropriate intrapartum management for her? Remember, the guidelines say that any woman who has had bacteriuria, even though the bacteriuria has been treated, the vaginal swab does not show any evidence of GBS, this woman will need intrapartum antibiotic prophylaxis to prevent early onset GBS infection in the neonate. So here she needs benzyl penicillin, and the correct dose of benzyl penicillin is you will give 3 grams of an intravenous loading dose and followed by 1.5 gram 4 hourly while in labor or till she delivers. Okay, so that is the correct option. And remember, GBS bacteriuria, it is an indication for intrapartum antibiotic prophylaxis. And benzyl penicillin is obviously the drug of choice. If there is an allergy, remember now vancomycin is given, clindamycin not given because there is a high risk of resistance. Okay, now you have another woman. She has GBS on high vaginal swab. She is 30 weeks pregnant and she has delivered previously by 2 cesarean sections and she is planning to have a 3rd cesarean section. She has no allergies. So what would be the proposed treatment plan for her? Remember, her vaginal swab is showing the presence of group B streptococcus. But remember, she is not going to deliver vaginally. That is the catch here. Only women, those who are going to deliver vaginally, need intrapartum antibiotic prophylaxis. Now, because she is going to deliver by a CS, the fetus is not at a risk of this infection. So, for her, no treatment is required. And her membranes have been intact. Obviously, she is going to deliver by a section before she goes into labor. Okay. Last but not the least, remember the sepsis 6 bundle, which says that it has to be initiated in the golden hour or in the first hour once sepsis has been diagnosed. So you will give oxygen to keep the stats over 94%. You will take blood cultures, give IV antibiotics, give a fluid challenge, measure serum lactate and measure the urine output. So if you initiate the sepsis 6 bundle in the first hour since diagnosis, the risk of maternal mortality is substantially reduced. Okay, so these were some of the important type of SBAs and EMQs that you would be encountering in your exam. I hope you found the video helpful. Thank you for watching the video and good luck to you for your exams. Bye bye, take care.